good afternoon or good morning, good evening, depending on where you're tuning in from. But certainly from here at Trinity College Dublin, good afternoon. And thank you so much for joining us as we continue here in the Department of Clinical Speech and Language Studies, our monthly webinar series, where we, as our staff members, are keen to connect with our colleagues both at home and abroad. So we're delighted for our March webinar to be focusing on the area of stuttering. And firstly, thank you very much to Paul Conroy and to Brendan McFadden, who here in the department coordinate our webinar series. But this month, we're delighted to have both Professor Amy Connery, Sir Assistant Professor in Child Speech and Language here in the department, who is joined today from across the Atlantic by Professor Bernstein Ratner from the University of Maryland. So thank you both for hosting today's webinar, and I'll hand over to you, Amy.
Great. Thank you, Julie. I'm just going to share my screen now. And if somebody can let me know if you can see that.
Yes, Amy, we can see that. They won't be able to respond, the attendees. It's they're automatically muted, so everything's fine. Thank you.
Great. Thank you, Brendan. Now, so hello, everyone. I'm delighted to welcome Professor Bernstein Ratner, who is a distinguished university professor at the University of Maryland. And Nan is here to talk to us today about the clinical management of stuttering for preschool children. And today's presentation, or rather a conversation, it will centre on a specific paper by Nan and also Shelley Brundage, who is based at the George Washington University. And this was published in the Journal of Fluency Disorders last year. And if you would like to, I suppose, learn a bit more about the things that we're discussing today, I'd recommend that you have a look at this paper. And then also I had the pleasure of attending Nan's keynote speech at the Oxford Stuttering and Cluttering Research Conference, which was on last September. And a lot of what we are going to talk about today was also discussed by you then, Nan. So just at the beginning of your paper, Nan, you provide a summary of how far we've come since 2005, when you would have written another paper, which was about evidence-based practice in preschool children. So 20 years have passed, and you discuss several areas that we've made progress in. I'm just going to touch on some of these now. So these include an increase in the published outcomes research, so particularly an increase in the number of systematic reviews that are available to access. Also, we have a broader view of effective therapy. So we can see more therapies that are less focused on speech change. So, for example, acceptance and commitment therapy or avoidance reduction therapy. And then another change in the last 20 years has been an increase in the presence of voices of people who stutter in research. And I guess a reconsideration of who the expert is when it comes to stuttering. And then finally, a greater variety of assessment measures that are more holistic. So, for example, the OASIS or the Palin Parent Rating Scales. So I wonder, Nan, if firstly you would like to comment on anything relating to these advancements that you so well discussed in your paper.
Well, sure. I'm old. And, 20 years ago, and further back than that, 40 years ago, when I entered the field, basically, we did things because our professors told us to do them. And we really had to take on faith, or at best anecdote, that certain things worked. I am old enough to remember non-stuttering speech pathology so-called experts in fluency telling members of our own profession who stuttered that their speech could be improved if they simply listened to their own advice on fluency shaping better. And, that sounds pretty outrageous these days in lots of ways to somehow personally attack a person's health status by, publicly suggesting that they weren't trying hard enough to manage symptoms or something like that. But I actually went to meetings like that, and my children remember friends of our family essentially being attacked publicly like that. So we've come a long way in that regard. Not only that, we're not only more respectful, I think we're actually paying closer attention to those messages, that people who have managed their stuttering see that the challenge in working with stuttering is not always to simply get the counts of stuttered events down. And that's, of course, fed devices like the OASIS, which is now available in many, many language communities. And I think this is, all part of a bigger picture that we want to be sure that we measure what we're doing to see if it's actually working. But we've also changed what we choose to measure to make it broader and a little bit more inclusive, as we would in any other walk of communication disorders or rehabilitative medicine. We don't always define good outcomes in terms of whether or not we have, certainly not whether or not we've cured the problem, but whether or not we've managed not even the symptoms in some cases, but the impacts of the symptoms, that we need to be more worried about that.
Great, thanks, Nan. I'm just going to, I guess, hone in on some of the knowledge gaps that still remain in preschool stuttering therapy. And this specific quote stood out to me whilst I was reading your paper, and I'll read it out now. For therapies to evolve and refine to meet the many needs of clients and families, it's important to understand not just that they work to accomplish some goal, but why they work, how they work, and for who. So we know that there are many effective stuttering therapies for preschool children. However, what we know less about is what is it about them that's working, or for whom do they work the best with? So maybe, Nan, if you'd like to comment on that.
Yeah, I think I'm married to a doctor, and he would listen to some of the debates going back to the 2005 article where a number of the authors suggested that they had isolated the best therapies for a particular age group of kids who stutter. And my husband was just kind of scratching his head, because in medicine, very rarely do you find some approach to a problem that works for everybody. And the real challenge is to pick among them mindfully, to understand why they might work, and also to be open to the notion that they might not work for that particular person, and that you might need to shift gears and try something else. In medicine, we actually have, reactions that are often inverse to what the rest of the population will do. So a medication that will make one person very sleepy, for instance, will jazz another person up terribly. And so the other thing is that there has to be some understanding of how things would work. A copper bracelet won't cure cancer, and people can sort of explain that to you scientifically. I personally have had real problems with a very popular approach to preschool stuttering, because I started out in child development, and I keep scratching my head trying to figure out why this therapy should work. And even if you report to me that kids are doing well with it, I still need to try and figure out, why is that true? Or is it merely that it is facilitating typical spontaneous recovery? Because the mechanism of action that the authors propose, this being, I'll come right out and say it, Lidcombe, which is proposed to be operant, we don't know of behavioral change that happens that way in other spheres of life. And so it's not clear how it manages to achieve reductions in fluency in children. So I think, for my perspective, maybe it's my home life, but and my background in child development, I'm basically trying to see why therapy should work so that we can make them better. We can remove burden and make things run easily. A recent article last year surveyed components in therapies for children who stutter, for instance, came up with somewhere over 60 active ingredients across many of these therapies. That's a lot of burden on therapists and parents. And so if we can figure out which recommendations seem to achieve some change and work us towards a goal of a certain sort that we mutually value, then we can tailor therapies to be more effective and more efficient. So I think that's really the work that needs to be done.
Great, Nan. And you've mentioned there one of the preschool therapies, and we'll just hone in a little bit on one aspect of your paper, which is the disconnects between therapy design and the known mechanisms change. And here we can see the two main groups of preschool therapies that you've discussed. So the LIDCOM program, and then also programs that are underpinned by the demands and the capacities model of stuttering. And importantly, in your paper, you remind us that these are effective therapies. However, you're questioning whether the specific the intervention components that are presumed to be the agents of positive change actually function as hypothesized. So, for example, with the LIDCOM program, it's questionable, particularly given recent research, that the parents' verbal contingencies or the comments that are provided to the child on their speech are actually responsible for the changes in speech, or the programs that are based on the demands and the capacities model, intervention components such as parents adjusting their speech rate, or maybe reducing questions that they ask. More recent research again is now questioning whether or not these specific intervention components are leading to the positive changes for the child. So maybe if you'd like to expand on that a bit, Nan, that would be great.
Yeah, I think I want to start with your first observation because I'm not sure that I agree with it. Okay, so that when we say that we have many effective therapies for children stuttering, we are often reporting in studies, often studies that have high dropout rates, unfortunately, before we do final follow-up, that somewhere in the order of mid 70% of participants show positive response to whatever the chosen goal is. The problem is that that's the rate of natural recovery in stuttering, as far as we know, gathered over somewhere over 3,500 cases over the years. And I probably didn't do full diligence in getting in every possible study that I could have collapsed. So when you have a condition that has a natural recovery rate that approximates 75%, you need hundreds and hundreds of children in clinical trials to show that you've moved that dial at all. And Shelley and I concluded after surveying the literature, Dr. Brundage and I concluded after studying the literature that we weren't really sure that any of these programs actually statistically fare better than that. And that part of what we may be seeing in effectiveness is that some therapies are effective in quickly moving some children through who would have moved through anyhow while we're observing them. The second thing that I'll say on this slide is that, to reiterate, the LIDCOM program authors themselves have done 3 research studies in which they've shown that verbal contingencies, which I never could figure out, as I said on the prior slide, I never could figure out why they should impact children's fluency rates, actually are irrelevant to impacting children's fluency rates. They actually ran a couple of controlled studies, not sure why, especially why they published it, that showed that if you simply play with a child, essentially, for a particular period of time each day, alone, in protected environments, that children's fluency improves regardless. And so the mechanism for proposed change, which are the verbal contingencies, and which I think do carry some potential harm if the child doesn't respond. So praising a child exclusively when they have fluent speech is sending a message of some sort. So we need to worry what happens if some children, even 2 or 3 children in 100, do not respond to a therapy like that. What is it that the parent and the child take away from it when they move to some other approach to their problem? The demands and capacities model is very near and dear to my heart because over the years, since I was a very young researcher, I've done lab-based research on some of the components of demands and capacities. And I always presented those lab-based studies as ways of palliating symptoms. In other words, ways that you could reduce the frequency of stuttering somewhat. It was never my intention for that work to be used as a substitute for therapy or as a simple agent of change in therapy. As I mentioned in the little tiny moments that we had before this session started, just in the past 2 weeks, Mark Onslow and his colleagues from Sydney Institute of Technology have published a new proposed therapy. It's not very new as far as I'm concerned, called 2-factor therapy, in which they're advising parents of very young preschool children simply to slow rate and enlarge the time between turn taking and conversations with their kids. And they present 3 case studies to suggest that it's effective in getting in essentially chasing stuttering away, essentially getting stuttering under a certain frequency threshold. And that brings us back to the header in a sense. One of their arguments is that these things need to be done during early preschool years because we know that young brains are plastic, and there's been a lot of research, wonderful research, a lot of it done by a colleague of mine, Sue-Ân Chang, that show that we can definitely distinguish brain structure differences between children who stutter and children who don't, children who recover from stuttering and children who persist in stuttering. And now the argument is being made that if we change the early experiences of children who stutter, we can encourage that plasticity and move them through and help them achieve lifelong fluency. I've written a letter in the past week, and so has Dr. Chang, because nowhere does any of our basic research suggest that the things that we do in the environment either create that plasticity or create that plasticity specifically for recovery from stuttering, or that the things that parents do have documented ability to essentially change the numbers that we know from years of study characterize recovery and persistence. So I think what we have is a disconnect between understanding finally, every time I get a call from some science writer talking about some new understanding, say in the genetics of stuttering, they're always somewhat blown away by the notion that it's not something that parents do to their kids. And so they call around to ask people, is this really true that they've identified these genes or whatever? So we have this kind of long-standing belief that something is going on in the environment of children who stutter that we can push around and change to increase rates of recovery. But we actually don't know that. What we know is that stuttering is highly genetic, and that stuttering does have with it known anatomical and neurophysiological markers that not only distinguish children who stutter from those who don't, but even kids who recover. And these are important basic science findings that are robust and have been replicated. And what we don't have in the clinical sphere is we don't have equivalently powered, equivalently informed, and equivalently knowledgeably interpreted results of the clinical trials. What we have is reporting that X number of kids develop stutter-free speech through any of these methods. But that's, number one, as you said, a narrow definition of what it is to work with stuttering. And number two, it's not clear that those numbers, if you're a statistician, actually offer any tremendous advantage over essentially just playing with your child and waiting for time to take its course.
And that's something that we'll touch on again in a couple of slides, Nan. But yeah. I just want to ask you a specific question, just in terms of the common factors. That's mentioned quite a bit in the psychotherapy discipline, less so, but nice to see it coming to the fore a little bit in speech and language therapy.
I know it's stuff that you're interested in too. We share that common interest, yes.
Yes, absolutely. And one example being the therapeutic alliance. So the relationship that a client has with the clinician can potentially create positive therapeutic change. And as I said, although much of the literature is linked to psychotherapy, the role of therapeutic alliance, we're seeing it more in speech and language therapy, but also in the likes of physiotherapy and their literature as well. I just would like you, Nan, to comment on what your thoughts are in relation to therapeutic alliance and its role with children and potentially with parents as well.
I think it's critical with parents, and I think that establishing a therapeutic alliance with parents of kids who stutter becomes more difficult when we lay a lot of recommendations on parents that somehow imply perhaps that if parents listen to us carefully and diligently do some of the things that we recommend, that they actually can have an impact on the child's outcome. That's why I think, in particular, in working with young children who stutter, that alliance, that therapeutic alliance between the parent and the therapist becomes really a tightrope walk If I had, a nickel for every time I explained to parents that all I was asking them to do was to do some things that might make their child's symptoms milder, in much the same way that if their child had asthma, for instance, I might suggest, choosing a different kind of pet. If they're going out looking for a dog, choosing one that doesn't shed, taking down drapes, pulling up, carpets, things like that to help their child. But that it's certainly not the case that the home environment created the asthma. Asthma is the result of many, many complicated physical, and genetic predispositions that the parents really had no say in causing or influencing. But once there, they can do things to help the problem somewhat. And I think that we do that in other disorders, but we haven't been as careful to do it in some branches of speech language pathology, but most certainly in stuttering. I think we'd do much better, for instance, in my other day job, child language, where we certainly tell parents that there are things that they can do to help grow a child's language. I just got an email this morning before this call about that. But we never intuit that somehow the child's slow language is the result of insufficient input or interaction. So we're better in some areas, and this does go back to the therapeutic alliance, which is it's very difficult to establish a great working relationship with a family if somehow our messaging keeps implying over and over again that if they listen to us, they're the agents of change. Because if nothing changes for the better, then parents don't feel very, very good about things. And there is a lovely book. It's kind of a hard read by Dory Holt called Voices Unearthed. That is reflections. She's not a scientist, but it's reflections of parents of adult children who stutter looking back on their therapy histories. And many of them feel a tremendous burden of guilt, even with therapists they liked, because when recommendations that they were given didn't pan out, they started to doubt either that the therapist was as knowledgeable as they were, even if they were nice, or that they were good, the parents were good at following through with recommendations, and therefore they felt guilty. And then when they start reading some more current literature that casts some doubt on whether or not the recommendations are sound or evidence-based, then they're simply mad, because they look at a possible good therapeutic alliance with the clinician to work with the child to help the child really address the impacts of stuttering, and lots of time has passed to no particular benefit. And so I think that's one thing that we have to be mindful of, is that there are real harms that can be caused if we're not particularly sure that recommendations are evidence-based. We're walking into a murky area in the therapeutic alliance, and we're taking away useful time and energy that could be spent, again, reducing the impacts of stuttering as we go forward.
Yeah, Dory Holt's book is a fantastic read. I would agree with that, Nan. Just
I think every therapist should read it, because to the extent that therapists really firmly believe, and therapeutic, common factors include things like a therapist's sense of security that what they're doing should work. But to the extent that belief is misplaced, we can do some harm. And so I think understanding the personal stories of folks who've spent their lives chasing certain types of therapy approaches to try and work with stuttering in various ways, some of the messages, some of their notions of what their goals should be have been perverted over time, and it's really very difficult to put that genie back in the bottle.
Yeah. Just extending that topic of common factors, and this is something that you do in your article, Nan, and you talk about the overlapping features of preschool stuttering therapies, and we have discussed some of this already, but just I suppose to make it a little bit more explicit. So we know that there are these overlapping features, and they include the protected parent-child talk time, praise, neuroplasticity, and rather than talking about therapies in terms of their differences, you highlight that it may be helpful to look at the similarities across the different therapies. And as I said, you have touched on this a little bit, but maybe just to expand on that a bit more for everybody.
Yeah, a lot of these therapies, if you take away, for instance, contingencies in Lidcombe, it looks a lot like Hanon therapy, which almost any pediatric speech language pathologist is quite familiar with. And Hanon therapy has been shown to be very good too, although I point out that it has some of the same statistical challenges. So many children move through language delay, but the Hanon program seems to have some decent effects on children's language growth. Certainly, we have hugely powered studies that say the more time that a child spends alone with a parent, just talking back and forth, language input is a tremendous factor in language growth. And language growth, in turn, is inextricably intertwined with brain growth. So brain growth enables language growth, but the opposite is also apparently true, that the more language that a child has, the stronger the language networks are, and those underpin many cognitive advances. I just went to a lovely talk in the past week that talk about growth in executive function, for instance, and growth in executive function appears highly mediated by language as well. And so if we have those particular features in an interaction, that's very helpful. There is a limited literature, but it's really fascinating to me, that talks about the role of praise in growing children's brain networks, actually. The role of praise is difficult because different children receive praise differently. And so while simply talking with children usually doesn't have any potential downside, except maybe you don't get work around the house done. When you praise a child, you have to be very careful to see the response, because some children like to be praised for effort. Some children like to be praised for results. Some children like to be praised for both. Some children like to be praised for neither. And if they get too much praise, for instance, they start thinking that adults are trying to send them a message that they're not doing a very good job in general. And so, but we were fascinated by the limited research on praise in terms of brain function, and a little scared by the very considerable literature on praise and how hard it is to do it right, as possibly explaining why therapies work. I will say in closing, I wouldn't put the role of neuroplasticity sort of to the side. I might put it below as an output of the praise and talk time. It's really something that happens as a result of those things. But the one thing that the literature has been pretty clear about in recent years is the one thing that praise does not do well in children, and any parents on the call, it doesn't change behavior well. And so praise does a lot for socio-emotional development and cognitive development, but it doesn't push behavior around very well. And that, of course, is the mechanism of action in Lidcombe, is that the belief there is that if you praise fluent speech, it will increase fluent speech. That is not a highly evidence-based notion, and would explain why, for instance, taking away the contingencies that sort of give you sort of verbal reinforcement consistently, I like the way you said that, nice, smooth speech, is probably not what is going on when children recover from stuttering during participation in that program.
Yeah, and I would definitely recommend the audience have a look at that section of the article that discusses praise, because sometimes there is one particular type of praise that is sold as being the best one, but you very clearly communicate the importance of the child's response to the praise as being the more important piece. So.
Yeah, I never thought I'd be using the word boomerang in an article, but when we did a dig deep kind of foray into the praise literature, the word boomerang kept showing up with somewhat alarming frequency, and that made us then import it into this article because it was cautionary in the very least.
The next piece, Nan, I think you have mentioned this already, but since we have this slide, let's just go through it again. And you discussed this really well at the Oxford conference as well, just to add, it's that issue of the spontaneous recovery from stuttering and our evaluation of preschool stuttering therapy outcomes. And you ask the important question, given that so many children stop stuttering with or without clinical assistance, do we have firm evidence that early intervention programs work? And there's a quote here taken from your article: statistically, the population sizes required to detangle spontaneous recovery outcomes from those influenced by intervention are quite daunting and beyond the capacity of most individual research or treatment sites. So there's currently no available RCT that, as you've mentioned, that has had the necessary sample size to discriminate between assisted and unassisted recovery. And maybe if you just want to summarize that one more time for us, Nan.
Well, when I go to cocktail parties with my friends in the field, I often make a prediction that if we ever do find something that improves on rates of spontaneous recovery and stuttering, that research will not emanate from the United States. It will emanate from perhaps Europe, or somewhere else in the world where we do not have decentralized medical care and decentralized school-based therapy provision. It will emanate from countries with national health services, integrated national education services, and places that can really run a clinical trial and do it with the right kind of fidelity and the right kind of size. So maybe the good news to take out of this is that many of the listeners on this talk are working in environments where if people combine their resources, maybe we'll get that kind of power. It is possible in the United States to do things that are called multi-center clinical trials, but usually in the United States, they're reserved for things that are considered to be more of a general health concern, like cancer. And so I do, and children in the United States are treated in local schools for the most part. And they're highly decentralized in the United States. A school system can be as small as one school. So trying to do this work in the United States is virtually impossible, but the good news is it might be very possible in other locations. So that's why I read the general literature, and I'm always very careful to read outside the American literature.
Maybe we can make a group from our audience today. Who knows?
Yep.
Just finally, Nan, because I know we want to move on and give some time to questions. I am aware that there are many SLTs that are part of the audience today that work directly with children who stutter. So my final question relates to your top tips for these SLTs. One thing that you asked me to integrate into today's discussion, and I think it's an essential one for our listeners to remember, is to think skeptically about promises that a therapy can prevent stuttering from becoming persistent. So we'll finish with your thoughts on that.
Yeah, so I want to credit Shelley Brundage, my co-author over many years on many initiatives, and good friend. She has also worked in the field of cancer advocacy, and so she's very good at reading the literature on how medical professionals communicate things to patients, particularly patients who want a cure. Basically, she was the one who brought up the concept that is called the anchoring bias when we talk to parents who stutter when we first see them. If we are not fully sure that therapy can change what happens when we see children who stutter early on in development, we possibly should not be emphasizing that 80% of children get better, but rather starting to say that only 20% of children will continue to stutter, but we don't know which ones they're going to be. Given that, what do we want for the child sitting in front of us? What are the parents' real wishes? And parents will say, well, what their wish is for the stuttering to go away. But if you look at them and sort of say, but why do you want that? Then you start having a more meaningful conversation, because then parents will say, oh, I'm afraid they won't have friends. I'm afraid they won't be able to say the things they want to say. I'm afraid that they'll be teased. I'll be, those sorts of things. We know we do know we can deal with that. We have the skills to reduce the impacts of stuttering, to help children talk more easily, to have them resist bullying and teasing, to understand their own condition better and have self-advocacy. Those sorts of things we know. And that's how we treat other conditions of childhood. If a child has asthma, seizure disorder, allergies, orthopedic problems, many of the, Dr. Connery knows that I showed a slide that had about 10 conditions of early childhood that we know to be physical and neurological that start in preschool years and often have a remission rate exactly identical to stuttering during that same time period. And in none of those conditions do we suggest that if parents listen to us carefully, their child will be in the recovery group. What we do is we presume that no child in front of us will be in the recovery group, and we start immediately to ask, how do we reduce the adverse impacts of the condition? And then if it goes away, that's kind of gravy. So what I really think that would be more useful for us to do in helping families and children who stutter is to assume that stuttering will stick around. And then if we made that assumption, how would we change the way that we start the conversations with parents and with the children about what we're going to do to help them? Then if stuttering goes away, that's kind of a real plus. But we shouldn't, I think we don't have the data to suggest that we have been effective in moving the dial to make it the case that if children get a particular type of intervention or parents do a certain type of set of behaviors with their child who stutters, that we have very sturdy information that that will change the course of whether or not the child remains persistent. And so I think it changes that assumption. Changing that assumption changes everything. It changes all the goals that we have. It changes all of our interactions with parents to be ones of mutual support for them and for the child. And I think that's sort of a win. When you read Dory Holt's book, unsystematic as it is, you come away with a sense of real loss, that therapists felt upset, parents felt upset, kids felt upset. If we can change that dynamic early in development and we can go towards support the way we do, again, for all these other childhood conditions, where we recognize that we don't see the future. So let's dive in on day one and start to minimize its impacts. Then I will think that we'll get a much happier set of interactions, and clinicians will really have a sense of achievement that we know from research many of them don't have when they work with families who stutter, because they're kind of seeing sort of random outputs from the therapies that they're in. Some cases work well, a lot of cases don't. They're not sure they see the differences. And so I think it really impacts clinicians' sense of self-worth in what they're doing.
Great, Nan, thank you. I'm conscious there are likely some questions that the audience have after all that we have discussed there. So I'm going to stop sharing now.
Yeah, as you look for comments, I want to emphasize, I'm not saying that clinicians can't do anything for little kids who stutter. I'm saying we can do a tremendous amount, but I think we've been diverting our attention in the wrong ways in some respects. Just because stuttering is not cured doesn't mean we have not worked effectively. We don't cure child language delay. We don't cure most conditions. We don't cure aphasia, the impacts of aphasia. We're not in that field. But somehow we've started to treat stuttering as though maybe it's childhood articulation delay. If we put kids in for a certain number of sessions, they'll come out sounding fabulous and they'll never come back. We won't need them to come back. But maybe, that's probably not why many of us entered the profession. And certainly after being in it for a while, we understand that.
Great. Thank you for that, Nan. I don't see any questions just yet in the chat, but I have one comment/question that I might just mention as we wait for more. And just a reminder, for anyone with something on their mind, please post it into the chat.
Yes, including being skeptical. I have a very thick skin, so if you don't like what I'm talking about, feel free to tell me. Feel free to throw thumbs down in the screen or whatever. That's the cool thing about Zoom meetings too.
I'm just thinking of the advancements that we've made with the social model of disability and neurodiversity, and that those were popping into my head while you were talking, Nan, and I guess that kind of aligns with many of the topics that you're saying. So do you want to maybe expand on, do these two things align, and will these different conceptualizations of disability support us with the endeavor that you're talking about?
Yeah, I mean, they definitely interact. I wouldn't say that, I think that for every person with a difference, kind of, they come from a different subpopulation of human beings. For every person who eventually decides that that kind of diversity is fine and they're fine with it, and they don't want people telling them to behave differently or function differently, there are people who don't agree. So I think, these movements have both folks who engage actively with them and people who don't. I think what's important in both the neurodiversity movement and in stuttering, which is a neurological condition, is that for very long, nobody was listening to opinions at all, not from the parents, not from the kids. And what will happen over a period of time, it certainly happened in medicine, for instance, when treatment of women's conditions, since we have a lot of women on the call, was handled by guys who made decisions on their own about what was best for women. And, obviously, as time went by, that got rethought. I think that we're sort of in the same place. And that's what makes it particularly important for us, not just to urge changes in behavior for neurodiverse individuals, and to make sure that that's what, in fact, they want, but to be sure that if we recommend things, that they actually do what we say they do. I mean, that's sort of a double whammy. In many cases in autism, they're not even saying that some of the interventions don't work. They're saying that they don't believe that they're necessary or desirable. But if you add to that the notion that people are being told to do things that actually don't change anything, that's, I think, a really, so our situation, I think, bluntly, is worse. Yeah.
I see there's a question here, Nan, and someone did mention that they couldn't use the Q&A. So hopefully,
Oh, well, that would explain. I was thinking, wow, this went over like a lead balloon.
no.
The Q&A is fine for the attendees. The panelists can use the chat. So the Q&A is
Oh, it
Oh,
is.
so you have to send it back into chat for us. Is that it?
Oh,
No, you should be able to use the Q&A now. Just if you look at the Q&A button at the bottom, you should see the questions as they come in.
For the participants. Okay. All right. I did see something.
yeah.
So, and there, I see Q&A here. Okay.
Okay.
The chat is disabled.
Yeah.
Okay. Clinical markers. Okay. So yes, that, let me just diminish this. So, we don't know. The question in the chat is, are there specific markers like frequency or types of dysfluencies, for instance? Actually, that is some of the stuff that doesn't get much coverage that fascinates me most about one of the data sets that we've been working with over the years, which is I administer Fluency Bank, and it's the recipient of the data from the Illinois Stuttering Research Project by Ehud Yeri and his colleagues. In their articles, one of the things that just astounded me, because nobody bothers to even think about it, I think sometimes when I hear people talk about predictors of persistence, one of them is never up on the board, and yet it should be. And it's like, well, you would think that severity of stuttering or the nature of the stuttering itself would predict outcomes. And the answer is, to date, no, it doesn't. What it does do is it predicts outcomes if you throw it in a few years down the pike. So as Purdue has shown, and some of the analyses of the Vanderbilt corpus, if you're concerned about whether or not the frequency of stutters, never the types of stutters in anything I've read, predict persistence, if you go in a year to a year and a half after, if you're tracking kids from onset, yes, the more a child is stuttering a year or so down the pike, the more likely they are to persist. It's kind of a self-evident problem, since a lot of stuttering goes away pretty rapidly. And so I don't think it really explains as much as it sort of says the obvious, which is that if you haven't outgrown stuttering a year or so after you've started, that's the most dynamic window for recovery, then we need to start pretty much elevating the assumption that the person will continue to stutter.
Okay, thanks, Nan. And then I just see the question before that. What are your thoughts on the Palin PCI?
I like a lot of, I'm not here to endorse particular programs, although it may sound like I just slammed one. I don't mean to do that, really. I think everybody's motivated to do the right thing. I don't think we have bad players in the field. I think that I like a lot of the components. And I do like programs that have a number of components. I still, and the most recent version of Palin is pretty good at, I think, getting parents to really first deal with their own thoughts about what will happen if the child doesn't stop stuttering. And I think that's where all therapies probably need to start. Is asking parents to change essentially why they came for help. Because when parents come for help for any condition, usually they just want the problem to go away. That's a very good parent wish. But if we start by having discussions about, how we can give the family and the child agency, those are good components for any of these programs out there. I see a lot of very good components. I'm more concerned about the difference between helping children to function better and using a therapy with the notion that if you use this therapy faithfully, you will increase the probability that your child will never stutter again. I
And
see one
then I
about
think in
parent anxiety.
what would
Yeah.
you recommend when counseling parents who are anxious about their child's disfluencies?
Yeah, I simply get down to brass tacks and kind of go, well, wait, why is that? Why does that make you anxious? And then we start to deal with what makes them anxious, not, they come in and sort of say, like, I'm an idiot, like, of course I came here because my child stutters. I want you to help fix that problem. It's like, but why does that bother you? And they look at me like I'm insane. And we basically try and get down to what exactly are they afraid will happen if the disfluency continues or the stuttering continues. And once we get down to that, we can work a little better. Of course, I, like most therapists, will never know if somebody really just walks away from me and doesn't engage, for years afterwards, whether or not I've solved the anxiety or I've simply sent them to somebody else. But that's my personal approach.
And again, a question here relating to parents. For preschoolers that aren't aware they are stuttering, would the focus be on the impact on parents'
Oh
attitude?
yes. Oh yes. I'm all for working with and that's been a real change in my life. I used to tell parents that if their kids weren't stuttering, because stuttering fluctuates a lot in early development. And when if a parent would call me and say, my kid hasn't stuttered for a couple of weeks, should I still keep my appointment? And back when I was more about the basic science, and we were talking about decades and decades ago, I would say, oh, just reschedule. Now I kind of say, oh, no, come on in. We need to talk anyhow. And so we just work on the parents, and because if the child begins to become sensitized, you want to be aware of what you're going to do at the time. I'm all for working with parents when kids aren't troubled by their speech. And the inverse is definitely true when parents sort of say, well, I've been told not to worry about it because it's only been going on for a little while. But a parent tells me the child's already started swapping out words. And I've had reports of 2-year-olds, like kids barely over the age of 20, swapping out words because they found something difficult to say. Then we need to see that kid immediately, because I don't care if it goes away or not. We need to deal with that immediate concern that the child's aware, the child's doing something, the child's concerned. How do we deal with that?
Great, thank you, Nan. In preschool children who present with mild stuttering-like disfluencies but no secondary behaviours or negative awareness, how do clinicians decide between monitoring the child and initiating early intervention?
Well, again, what do we mean by early intervention? So a number of things can help modify the frequency with which you see some of these behaviors. Parents also report them to be incredibly home calming, by the way. Those of us on the call who are parents, is like, if you slow down the pace of interaction, you do more than reduce the frequency of stutters, for instance. I think that if children are not concerned, we don't necessarily call attention to their speech, although there's nothing wrong with doing it. I want to point out that I want to give fair airtime here. The one thing that Lidcombe has done over the years is convincingly bury the Johnsonian legacy that you shouldn't pay attention to stuttering, because whether or not Lidcombe changes recovery rates statistically, by all accounts, calling children's attention to their speech should make it worse. And clearly it doesn't do that. We know that by now. So I think that if a child's unconcerned, you keep working with the parent's concerns, you keep maybe recommending things to try and then provide feedback on, like, did that help? Did that change anything? If not, okay. I don't think there's this notion in language between watch and see, wait and see and watch and see. Wait and see means see me in a year. Watch and see means let's try some things and see if anything changes for the better compared to the day you walked in. And let's maintain some attenuated contact, but let's continue to use some, how are some strategies that I can give you working in terms of creating comfort in the environment, reducing your anxiety, and so on and so forth.
We will finish on this one last question relating to outcome measures, Nan. What kinds of functional outcome measures do you think are most important when working with children who stutter?
Yeah, I think a sense of comfort in speaking, that they can get their words out. So I'm a great believer in certain tools to help kids get their words out. So good old-fashioned speech tools if they're stuck. And so they have some agency in the same way that we teach them how to monitor, glucose levels and respond if they're having, low or high blood sugar on a monitor, for instance. You want to give them that agency, and you want to give them tools to achieve that agency. You do want to make them resistant to bullying and teasing, which occurs with these other conditions as well. And I think we just want to sort of, probe deeply with the parent and the child. Has anybody been giving you a hard time? And what can we do about that? And I think we want to give the parents agency to create a better quality of life for their kids, without making them unwittingly or intentionally somewhat responsible for determining the outcome for their kids, which I think is just not a friendly way to start a therapeutic relationship with a family, and one that I find uncomfortable when it's not evidence-based.
Thank you, Nan. I'm going to read out a lovely comment here from Christine Blomqvist. Apologies for the mispronunciation. I just want to thank Nan for this webinar and also her article and talk in Oxford. She's bringing forward important nuance in the discussions in our field worldwide. Her work and words is helping us SLPs and our clients worldwide.
Well, thank you. That is very, very kind. And I'm just very grateful that it's being received that way, because my goal again is to help everybody involved in this process. And my major regret actually is that I couldn't pull the pieces together myself earlier in my career. At my age, it's kind of all I can do is go out there and talk as much as I can now and hope that other people will pick up the challenge and see if we can move in slightly different directions going forward, to make, the quality of life better for families.
Well, Nan, you're doing a super job. Thank you so much for today. Thank you for your time. And it's always an interesting discussion with you, Nan. And thank you everybody for joining us. The recording will be available at a later date. But yeah, thanks again.
And Nan. I'm a pretty good pen pal if people want to write me with thoughts, pro or con. I actually came into this field after being a debate coach, so I'm pretty able to, disagree respectfully with people. So it's not a problem for me. And if people want to give me any feedback, because we're continuing to work on some of these problem spaces from a research base, as well as sort of pulling data together. And so any sort of input that people can give me or reactions that people can give me will be very helpful and very gratefully received.
Sounds great, Nan. Thank